சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும், நல்லவற்றை உள்வாங்கவும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ நம்பர். ஓவர் டு யூ.
Rajkumar sir, we really welcome, we are very happy to welcome Dr. Singaravelu sir after his elect as President-elect of 2026. This is the first online meeting I think he's attending after being elected. Sir, it's such a pleasure to have you. So now I request Dr. Rajendran sir to welcome the gathering and also to welcome Dr. Singaravelu sir. Thank you Dr. Rajendran sir for joining in spite of your hectic schedule in Hyderabad in Critical Care Conference.
Thank you, Dr. Narmada, and most respected our humble President, Dr. M. Singaravelu sir, and scientific advisor of IAP-TNSC. On behalf of IAP-TNSC, really appreciate Dr. Singaravelu sir, who has won the President 2026, and officially I want to announce it. And thank you, sir, for joining. I welcome Dr. Palasankar sir, President 2024, and Swaminathan President-elect, and Gopal Subramaniam, Vice President, and our dynamic Secretary, Dr. Narmada, and Dr. Rajkumar, Treasurer, and Central as well as State EB members who has joined here. On behalf of IAP-TNSC, welcome one and all. Today's topic of discussion is infant with jaundice. So I welcome faculties from Trivandrum, Dr. Prasant, and as well as Dr. Aravind from Government Medical, Pudukkottai Medical College, so that both are renowned pediatrician as well as Dr. Prasant is a gastroenterologist, and Dr. Aravind is associate professor at Pudukkottai Medical College. On behalf of IAP-TNSC, welcome. Today's a mentor from Kanji Kamakodi Child Trust, Dr. S. Srinivas, is again is pediatric senior consultant as well as pediatric gastroenterologist also. On behalf of IAP-TNSC, welcome. And today's learners are Dr. Dharani and as well as Dr. Ananda Narayanan. Dharani and as well as Ananda Narayanan, welcome on for this proceeding. And so actually it's almost we are close to thousands of more than 1,000 postgraduate teaching program as well as CME. I think it is available in the IAP-TNSC website and as well as YouTube channel also. I think all the postgraduates as well as faculties use this opportunity to IAP-TNSC YouTube channel to enrich their knowledge. And because of IAP-TNSC, I welcome one and all. I really appreciate that Kritika is a person who is coordinating this postgraduate teaching program, and currently she is senior assistant professor at Tenny Medical College. On behalf of IAP-TNSC, I really appreciate Dr. Kritika effort also. So thank you very much, Dr. Narmada. Please proceed. Yeah.
Thank you so much, Dr. Rajendran sir. Now I request Dr. Singaravelu sir to give his felicitation for the postgraduates. You are a source of great inspiration, sir. Thank you so much. Please, sir.
Thank you, Dr. Narmada, the most dynamic president of IAP-TNSC. I can say a visionary president, Professor Dr. Rajendran, and ably supported by our secretary, Narmada, treasurer, Rajkumar, and immediate past president, Professor Balashankar sir, and Somasundaram, president-elect. And our academic coordinator for this program, Dr. Kritika, who is doing wonderfully well continuously. And today's program, the two faculties and Professor Dr. Prasant, very simple, humble, but very dynamic academician, gastroenterologist, where I could visit his hospital in SAT. His sincerity and discipline cannot be explained, because I visited his OPD, how big the crowd was and how he was managing individually, and without even when I went there, he never came out of it because he was very conscious about his work. Really hats off to Prasant sir. And many times I want to bring him to our academics. Somehow he was held up in several programs, but today definitely he should be there. I requested, then he postponed his today's commitment. Thank you for joining. and Professor Aravind, my good friend from Tanjavur, presently as Associate Professor at Pudukkottai Medical College, and all our postgraduates who has joined, and our mentor, Dr. Srinivas, son of Dr. VSS. So today is a very wonderful team as involved. Why I am telling this? Because we achieved a historic thing that I won the election. Lot of things are behind it. One is this PG teaching program, because wherever I visited medical college, and the faculties as well as postgraduate, sir, we are seeing all your teaching programs and YouTube, which was very, very, very useful for us. So we are using that subjects while we are taking classes. This is not just for sake of convenience. This is what's the information I got when I traveled across the country, lot of medical colleges. So we are very proud that our Tamil Nadu, under the leadership of Rajendran and the team, is doing extremely well in academic. And I should thank at this juncture for making me as a scientific advisor for this year, which has reached throughout India, which helped me in election campaigning, and the unity of Tamil Nadu, which made us to win. Thank you all for being with Sukas. I don't want to take much time because it is being an academic session. Once again, I thank all the office bearers and all those who are involved in that election process and made a great victory for Tamil Nadu. So with this, I congratulate all the postgraduate who make use of this program, where our president and the team has made meticulously. So each topic is very useful, and Kritika and others are doing very well. So be benefited out of it. Thank you. Thank you. Wish you all that happy learning. Thank you.
Thank you so much, Dr. Singaravelu sir. In fact, the unity and the help of these programs and the postgraduates has been a real great help in the election campaign. As we proceed, Kritika, your enthusiasm is really very, very nice. And this is the penultimate session you said for this year, but I hope you'll continue for the next year also to deliver yet another interesting session. And also for me, this program is very special because Srinivas has been my classmate and very close friend, and we have studied together for the DNB. So I know how much he puts interest in teaching even during his postgraduate days. So being throughout this journey, it's so nice to have Dharani and Anand and to be mentored by him. We are listening. We are very interested to listen, and we have SAT Trivandrum is one of the pioneers in pediatric care, and we had the opportunity to be there for more than 10 days because we had the developmental center there where I learned my PGDDN, as well as Dr. Aravind sir. I know very closely. His family also very interested in academics. So it's a very nice special session. And Dr. Thirumurugan, our academic coordinator, do you really want to say a few words? Okay. Thank you. I know, sorry, though that's the election campaign. Yeah. So, Dr. Kritika, over to you for yet another interesting session. And jaundice is always a point of contention for both practitioners and the students. Over to you.
Thank you, ma'am. Thank you, ma'am. Respected Rajendran sir, respected Singaravelu sir, dear Narmada ma'am, dear Rajkumar sir, Thiru sir, Balashankar sir, Somasundaram sir, and Gopal Subramaniam sir. Everybody, good evening. And we are there for the 11th session of this IAPPG Masterclass for the year. And we are here to listen to the story of an infant with jaundice, going to be presented by Dharani and Ananda Narayanan under the able mentorship of Dr. Srinivas sir, who is a senior consultant at KKCTH Chennai. And to assist them and to fine-tune them, we have with us two eminent faculties, Dr. Prashant K. Shoban, who is the Associate Professor of Pediatric Gastroenterology from the eminent SAT Hospital of Trivandrum, and Dr. Aravind sir, who is the Associate Professor of Pediatrics from Government Pudukkottai Medical College, Tamil Nadu. So may I ask Dharani to share her screen and start presenting the case. Dharani?
Good evening, ma'am.
Good evening, ma'am. Please, you can share the screen. Yeah, your slides are visible, ma'am. can start
Good
presenting.
evening. Good evening, everyone. Thanks for this opportunity.
Now over to Prasant sir and Arvind to supervise. Okay, sir.
Thank you. Thank you.
Good evening, sir. Sorry for the confusion in the topic. This is a child with upper gastrointestinal tract bleeding.
Yes, yes, ma'am.
Master X, 2 years out of third-degree consanguineous marriage from Anandpur, Andhra Pradesh, whose informant is mother and reliability is good. Came with the chief complaint of fever for a day, followed by history of vomiting blood for 5 days and passing dog stool for 3 days. History of presenting illness. The child was apparently normal till 10 days back. Then he developed fever for 2 days, which is low grade, intermittent in nature, not associated with rash, which was managed with oral paracetamol and subsided. History of blood in vomitus, 2 to 3 episodes per day, more in the early morning hours, painless, about a fist of the mother, initially bright red with food particles, then it became brownish associated with clots. It's not associated with retching. History of passing dark stools from next day of the vomiting, which were 3 to 4 episodes per day, sticky, blackish, semi-solid in consistency, filling the diaper each time, which lasted for about 3 days. For above mentioned complaints, he was treated at nearby hospital with IV fluids, IV injection, and blood transfusion, and he underwent endoscopic procedure and referred here. There was no history of yellowish discoloration of the eyes, no history of itching or pale colored stools or high colored urine, no history of skin bleeds, no history of abdominal trauma, no history of irritability or excessive drowsiness or altered sleep pattern or abnormal movements, no history of abdominal distension or decreased urine output or swelling of legs or patches in the skin, no history of bone pain, joint pain or skin rash, no history of any native treatment prior.
Now, Dr. Tharini, can you please switch off the video? Switch on the video.
Yes, sir. Yes.
Please go to your initial slide.
Mm. Mm.
It's
Previous
not
slide.
moving, ma.
The initial slides. The initial.
The first slide.
Yes. The first slide. The second one. I mean, second one. Yes, this one. Next one. Next slide. Next one. So if you take these initial 2 slides as the template, what do you think the boy is having?
The boy with hematemesis and melena, sir.
Why do you say Melina?
Passing a blackish semi-solid, which is sticky stools,
Okay.
which started after hematemesis, sir.
Started after hematemesis. What do you think about the severity of the bleed? I mean, if the child is hemodynamically stable or child is not hemodynamically stable.
The child is hemodynamically stable only, sir. It is not so severe bleed.
The history of requiring blood transfusions
Other
that it could.
Other than that, how do you
That-
gauge? How do you roughly gauge whether the bleed is hemodynamically significant? You have some suggestion in your history.
Fist of the mother, amount is about fist of the mother.
Clots, passing
So
clots
if
in
it
the
is,
vomit.
so it is about the size of the fist. Roughly it translates to how much ml of blood?
30 ml.
No. It's 50 ml of blood with clots and all. It translates to how much? 50 ml with the clots.
Significant bleed only, sir.
No, it is significant bleed
see.
only. But other things you have to just look into. This is not a simple thing that you have to be very, very cautious. This is not 50 ml or 30 ml. It should be minimum somewhere more than 300 to 400 ml blood would have been lost. Okay.
Yes, sir.
So before going to the negative history, what do you think as the cause for the bleed? Or suppose I ask you, if it is not a GA bleed, how do you contest my statement that this is not a GA bleed? Suppose I say that this is hemoptysis, how do you contest?
There is no history of URI symptoms or cough, sir.
But there also you can get blood in the vomitus. If you take off the lower GA bleed,
It is painless bleed.
there also you can get painless bleed.
No respiratory symptoms and significant melena. Quantity of bleed is huge.
Yes. That gives an indirect clue that it could be the source of bleed is from the GI tract. So can you make any assumption regarding the site of bleed? Is it from the upper GI tract or lower GI tract? What do you hope you
Upper
got the
GI
question?
tract, sir. It
Until,
is from upper GI tract, sir. Because
until what region you call it as upper GI tract and beyond which you call it as lower GI tract?
to ligament of treats, sir. First
Yes.
part of duodenum, sir. Second part of duodenum, sir.
So you are able to come to a conclusion that this is a GI bleed, which is fairly significant and probably from a upper GI tract as of now.
Yes, sir.
Okay.
Yes.
Next slide. So you have elaborated a whole lot of negative history. What is the sanctity of each of these statements? What are you trying to rule out by these statements?
So no history of yellowish discoloration of eyes. There is no associated jaundice, sir. And no history of itching, pale colored stool and dark colored urine. There is no significant cholestasis is not there. And no history of skin bleeds. There is no other bleeding manifestations except this upper GI bleed, sir. No history of previous abdominal trauma.
What is the importance of that statement?
Previously, any abdominal traumas which may lead to
Bowel
injuries and
More
splenic injuries.
More than that, no, splenic injury cannot go unnoticed like this. More than that, in the context of upper GI bleed, what is the significance of this abdominal trauma and GI bleed? How do you correlate? What pathology can probably explain upper GI bleed? Spleen injury, for that matter, cannot go unnoticed for that reason because it may be catastrophic if it is the bleed is of this much size. Which pathology you are referring to in terms of abdominal trauma that can cause upper GI bleed? Okay, we'll come back. We will come back to the question at a later point. You proceed with the other negatives.
Irritability, excessive drowsiness, and altered sleep pattern and abnormal movements. There is no hepatic encephalopathy is not there to rule out hepatic encephalopathy. And abdominal distension, reduced urine output, and swelling of legs. These history are for liver failure symptoms. There is no liver failure symptoms. Bone pain, joint pain, and skin rash are to rule out malignancies. And there is no
only malignancies.
No, sir.
It's just
Only malignancies.
Yes, sir.
What do you call those? What do you call that group of disorders?
Connective
tissue disorders or autoimmune disorders,
yes,
probably.
sir. And
Now it's still native treatment.
sir.
Native treatment, specifically, what are you trying to roll out, ma? In this context, in this portal hypertension context, native treatment specifically?
Sir.
Anything specific?
Liver any liver disorders, sometimes they may take native treatment. Following that, they may have portal hypertension and bleeding may be there, sir.
No, sir is asking what sort of native treatment or what component in that native treatment can you correlate with this kind of presentation? If you think in terms of portal hypertension, he has given a clue also.
Herbal medication leading to liver failure, sir.
No, what content? Probably sir is hinting in that
Arsenic.
possibility.
Heavy metals. Sir.
Which heavy metal?
Arsenic.
Which heavy metal?
Yes.
No, it is arsenic. So some of these Siddha medications can contain this kind of this thing. No, if consumed in small doses or over a long period of time, probably that can lead on to some of the portal hypertensive pathologies. Okay.
Also, this pyrazolidone alkaloids are a common cause for post-sinusoidal portal hypertension.
Yes.
Herbal tea content. So that is important for this history, negative history.
Okay, sir.
Okay. Please proceed.
Proceed.
No history of similar complaints in the past. This is the first event. And there no history of any abdominal surgeries. He underwent endoscopic procedure at outside hospital for the same episode, sir.
What is the sanctity of the statement? No history of similar complaints in the past. No history of abdominal surgeries. How do you?
Sir, this is the first episode of vomiting blood and melena, sir. No previous history of any similar kind of history.
Suppose he had previous history of bleed. What could be the reason?
Variceal bleeding can be presenting as recurrent upper GI bleed, sir.
You missed something very, very important in the negative history. What is that negative history? Your discussion is highly skewed towards one particular entity.
Yes, sir.
You take off all those components. You just think in a little broader way. This is a toddler who may be, they are fond of exploratory behavior. Childhood.
No history of any foreign body injections.
It's very, very important. No, that should have come as a negative history. That history may not be available in the first grade. Do you think that it is important?
Yes, sir.
Yes, sir.
Yes.
Lead to trauma, and if it is not removed, they may lead to recurrent in
especially ingestion of which foreign body?
Button batteries.
Yes, button battery. Button battery can be catastrophic sometimes. Okay. Here you mentioned about no history of abdominal surgery. What sort of abdominal surgery you are interested into?
Appendicitis and any peritonitis, abdominal infections are a risk for portal vein thrombosis. Any
and hepatic cause, and previously
as far as your history is concerned, there is no suggestion of hepatocellular dysfunction. So how that can be explained? What other negative history you should have definitely asked? I mean, what other past history you should have definitely asked? Okay, we'll come back to that later. Please proceed. Arvind sir, anything to be asked?
Hello, sir. Nothing.
Oh, right.
Okay.
Antenatal history. Pregnancy was registered and mother was immunized in a nearby PHC. No history of fever with rash or post-auricular lymphadenopathy. No history of any drug intake, radiation exposure in the first trimester. No history of diabetes, pregnancy-induced hypertension or hypothyroidism. Antenatal scans were normal, and mother had taken iron and folic acid supplementation. No significant antenatal history. Natal and postnatal history. He was a full-term, normal vaginal delivery. Birth weight was 2.8 kg. Cried immediately after birth and breastfed within an hour. Birth vaccines were given. He passed meconium and urine on the same day. There was no history of any NICU stay or umbilical venous catheterization at birth.
Why did you specifically mention about no history of NICU stay or umbilical venous catheterization?
Sir, any sepsis in the neonatal period and required NICU stay or umbilical venous catheterization may lead to thrombosis of the portal veins.
Okay. Fine.
Sepsis, in the specifically any sepsis, no? Particularly, which sepsis are you worried about? As far as extrahepatic portal vein obstruction is concerned?
Omphalitis.
Omphalitis. Okay. Okay, proceed.
Immunization history. He was immunized up to age according to national immunization schedule. BCG scar is there. He received last vaccination at 1.5 years of age. No optional vaccines were given. Developmental history. He attained age-appropriate milestones. At present, he is able to run well, plays with other children, speaks many words with meaning and 2-word sentences. Nutritional history. He takes mixed diet at present. According to 24-hour recall method, required calorie intake is 1100 kilocalorie and he is taking 960 kilocalories and deficit of 140 kilocalories, and protein of 13 gram is required. He is taking 12 gram and deficit is about 1 gram. Family history. There is no history of bleeding disorder or liver disorders, stroke or sudden death in young age, and recurrent blood transfusions among family members.
What is the significance of each of these things?
Bleeding disorders.
How common is GI? How common is GI bleed in the setting of bleeding disorders? What sort of bleed you get commonly in bleeding disorders? Is it GI bleed? Is it GI bleed or mucocutaneous bleed?
Mucocutaneous bleed is more common.
Okay. The liver disorders? What do you have in your mind? Especially when there is no history of hepatocellular dysfunction, but still you want to consider portal hypertension as a probable pathology. So what is in your mind? From a family history point of view?
Congenital hepatic fibrosis in childhood and
congenital hepatic fibrosis. Suppose if you consider congenital hepatic fibrosis, what other additional family history you would have asked?
Any similar history in siblings?
More than similar history, which other organ involvement you should specifically ask?
Pulmonary.
Not pulmonary. It is the renal disorders. No, this congenital hepatic fibrosis and the cystic disorders of kidney, they have got a fairly good association. Okay. What is the sanctity of the statement stroke or sudden death in young age in relation to this case?
Prothrombotic states, prothrombotic states that is running in the family.
Which prothrombotic state you are probably hinting at?
Protein C, protein S deficiencies.
Other than that?
Antithrombin 3 deficiency.
Which one?
Antithrombin 3 deficiency.
Anything else?
Homocystinuria.
Homocystinuria. Okay. Okay. Please proceed.
Socioeconomic history. Lives in a Paka house with separate bathroom and kitchen. They belong to upper middle class as per modified Kuppasamy scale. 8-year-old male child born out of 3rd-degree consanguineous marriage, presented with hematemesis and melena, with no history suggestive of chronic liver disease or coagulopathy. Child with upper gastrointestinal tract bleeding, probably variceal bleed due to portal venous hypertension.
I think this second statement you are not able to make at this point of time. I'm not happy with the second statement. I'm only happy with the first part of the second statement, but probably variceal bleed due to portal venous hypertension even before examination may be a bit high-handed. Arvind sir, your take on this?
Yes, sir. You're absolutely correct, sir. You cannot make a statement.
You should always keep, I think, the room open for discussion. If you close it now, you will land in trouble. This is a learning session, so we will be You may feel that it little bit of nagging, but I'm just telling the actual situation. If you make it a closed area, no, you will not get that space to negotiate further. So keep all the options open and do not, and please refrain from making judgmental sentences. This is like a judgmental sentence, like you have already committed even before examining. So that may be avoided. My suggestion.
As they underwent endoscopic procedures outside.
No. All those things. No, even endoscopic procedure can be done for a button battery also. How can you be sure that it is only done for portal hypertensive bleed? Especially the age group is that particular age group, no, where she can very well have history of foreign body ingestion.
Yes, sir.
Okay, so probably at this juncture, what are the differential diagnoses you would like to consider?
As initially fever followed by UGA bleed, viral hemorrhagic fever may also be a DD score.
Even a simple fever, simple viral fever with the gastritis can cause upper GI bleed, especially in the backdrop of NSAID intake. Here though, there is no history of retching, so Mallory-Weiss clinically may not be a possibility, but still it can be considered.
And next to that, foreign body ingestion may also be there, sir. Yes.
But you don't have any history either.
Yes, sir.
You are not asked that history.
Yes.
So what are the other possibilities? Here comes, you had mentioned about history of trauma. So you mentioned about splenic trauma. Sometimes if you get pancreatic trauma, probably you can get upper GI bleed as a consequence of. Sometimes they may develop a condition called pseudoaneurysms that can cause upper GI bleed. Upper GI bleed means it can be bleed from the esophagus, it can be bleed from the upper part of the GI tract, it can be bleed from the biliary tract, it can be bleed from the pancreatic. So all these organs can be involved. That is the importance of anatomical localization. From the history, you are able to make it out that this could be probably an upper GI bleed based on the available history, but we are not clear about the pathology at this point of time. So we'll keep all options open. Arvind sir?
Yes, sir. Sure.
Please proceed with the, so if you are permitted to do a single examination, what is the finding that you would be interested to? Tharani? You are permitted to examine, you are permitted to look at a single finding. What will you look at?
Examination of abdomen, sir.
Specifically,
Finding spleen, whether there is a
why?
Sir, in total hypertension, whether in total hypertension there will be splenomegaly.
Sometimes you can be, you have considered, are you considering a cirrhotic pathology or a non-cirrhotic
Yes,
pathology?
sir. Whether there is a liver or not, we should check, sir.
Clinically, it seems that there is no hepatocellular dysfunction, so you are not considering a cirrhotic pathology. You are considering a non-cirrhotic pathology.
Yes, sir.
So what else? Spleen, apart from spleen?
No. Whether there is icterus or not, clinically.
No. Okay, you go ahead with the examination.
Child was conscious and lying comfortably on bed. Pallor is there. There is no icterus, cyanosis, clubbing, or generalized lymphadenopathy or pedal edema. There is no petechiae, ecchymosis, or purpuric spots in the body. There is no bite spot, or erythema, or scratch marks, or spider name. Anthropometry. Weight is 10 kg for the expected weight of 13 kgs, which is less than third centile, and height is 90 centimeter, and for expected height of 92 centimeter, which is 5th to 50th centile.
You could have presented a growth chart along with this, no?
Yes.
You could have presented a growth chart. The growth chart could have been displayed, indicating what growth chart have you used? Which one have you taken?
So WHO growth charts. WHO growth charts.
WHO 2006 and IAP 2015, the modified growth chart, yeah. So that you could have plotted.
Yes,
you could have plotted and displayed. That would have been better. Because
Okay,
this weight 10.9 kg for a 2-year child less than third centile, I'm not convinced. Is it so?
just below third centile, sir. 2 years and 6 months, sir.
Okay. So in a real examination, we can physically verify. So in online examination, at least you could have displayed a growth chart that would have been better. Okay.
Do you think
Sure,
that anthropometry evaluation is very important in this case?
Yes, sir.
It is very important, but okay, we'll come to that later. It carries some more importance also, apart from the usual importance. Okay. Proceed.
Vitals, temperature is normal, 98.6 degree Fahrenheit, and pulse rate is 122 per minute. Regular
1 minute,
rhythm.
ma. You didn't mention about mid upper arm circumference. You don't think that is important? Huh? Anthropometry, it's not only weight and height for children.
Yes, sir.
That too, it is under 5. Under 5 children, you need to have MUSC. Mid upper arm circumference is mandatory. You could have also added head circumference also. Head circumference, chest circumference could also have been added.
Sir.
So that too, when you are committing it as less than third centile, we want to know whether it is SAM or not, with other criteria also.
Okay, sir. Okay, sir.
That should have been better. I think anthropometry is a little bit inadequate.
Sir.
It should be more elaborate, as are told, with all the proper interpretations. So it would have been nicer if you had put up in a growth chart.
Okay, sir.
Okay.
Please proceed.
Vitals, temperature is 98.6 degree Fahrenheit and pulse rate is 122 per minute, which is regular rhythm and normal volume. Felt equally in all peripheral pulses were well felt. Respiratory rate is 28 per minute and abdominothoracic type. Capillary refill time is normal. BP is 98, 56, 60 millimeter of mercury. In the right upper limb measured in the sitting posture, which is between 50 to 98 centimeters.
So what is your assumption after these vital signs regarding the hemodynamic status of the child?
Child is hemodynamically stable as of now, sir.
You feel it is stable?
Tachycardia is there, sir.
Which one?
Yes, sir. Heart rate.
Do you think that hemodynamically is stable?
Yes,
Yes or no?
Yes.
Why?
Sir, 2.5 years, heart rate is till 4 years, heart rate will be more than 100 minutes.
What about the pulse rate?
Pulse rate is 122 per minute, sir.
Arun sir?
It is a little bit on the higher side. I think the higher upper limit will be 110. 100 to 110. 122 is a little bit on the higher side.
I would have been happy if you had mentioned one more vital sign, which is not a difficult thing nowadays, because all of you carry that handheld props in the OPD. What is that, Tarini?
Saturation.
Yeah, yes, saturation. Why? What is the sanctity of that thing in relation to GI bleed?
There may be.
Okay, we'll come back to that later. Please proceed.
Examination of the abdomen.
No, this is not the way. No, you are directly going to you are not mentioned the head to foot examination, or this is the usual pattern?
Head to toe.
Okay.
Head to foot you mentioned?
No, sir.
Why? Why?
Okay.
Do you think that it is not significant?
Significant in this, sir. In
No,
general
then-
examination, I added in the last, sir.
No, not the general examination. Head to foot, I want little more details. So sometimes you will get a very important clue regarding the etiology just by looking at the oral cavity. The problem is now you are heavily skewed toward that particular diagnosis. That is why you are revolving around that particular thing. This is the usual mistake committed by all the residents. They will have the diagnosis fixed and then they will twist the history in such a way that it suits the diagnosis. That should not be the way. You should think very broadly. You should be able to make a set of differentials based on the history. And based on that, then you proceed with the examination. Now that it is highly skewed towards a particular diagnosis, whatever it may be. Suppose I say that you have to look at the oral cavity. What is the finding that I am referring to? Especially at the undersurface of the tongue, you happen to see some telangiectasias.
Yes, sir.
Do you think that it is significant?
Yes, sir.
Yes, sir.
Yes. What way it is significant?
Connective tissue disorders.
Not connective tissue disorder. I am interested.
Hereditary hemorrhagic telangiectasias can
Can it
present.
cause portal hypertension and bleed?
Sir.
Yes. Similarly, you mentioned that there is no. Suppose there was clubbing. Suppose there was clubbing here. What could have it been?
Hepatopulmonary syndrome.
Yes, the same thing with the clubbing hepatopulmonary. That is why I am insisting that you should have looked at the pulse oximetry also.
Yes, sir.
Okay. Arvind sir?
Yes, sir. Yes, sir.
Anything else?
Yes. Yes, sir. I also expected them to present general examination in detail, sir. Inadequate, actually.
Inadequate. Okay, Dharani, please proceed.
Examination of the abdomen. On inspection, abdomen is mildly distended, umbilicus is normal, and flanks are free. All quadrants move equally with respiration. There are two small dilated veins over the epigastric region. No scars or sinuses. Hernial orifices are free, and external genitalia was normal.
Okay. I would say that you are please go back. I would say that your inspection is incomplete. What way your inspection is incomplete? You are having a perspective from one side only. I'm giving an indirect clue. What is the name of the boy who is sitting near? The Taran is Anand. Anand. What have you missed? Inspection.
Back of the abdomen,
Yes.
there are no dilated veins.
Yes. Why that is important, Anand?
In upper IVC obstruction or
yes, very good. Very good.
Dilated veins in the back are a clue towards the diagnosis.
Yes. So inspection means it has to be a total inspection, not only from the anterior aspect, posterior aspect, and flank. All should be explained. You should examine.
Okay, sir.
Proceed.
Proceed.
Palpation, abdomen is soft. There is no warmth or tenderness, no guarding or rigidity. Liver is just palpable below the right costal margin, and span is about 6 centimeter. Spleen is palpable till the level of the umbilicus. 5 centimeter from the left costal margin along its axis. It is non-tender, firm in consistency. Notch is not palpable. Moves with respirations.
Okay.
No other abdominal organs were palpable.
No liver palpation. Your description is not complete.
Sir, it is firm in consistency, sir, liver, but it is just
okay.
Just palpable, sir. Only tip is palpable, sir.
At the level of what? Along the mid-clavicular line or what?
Along
That
the
should be
mid-clavicular.
slip-weight.
Sir, along
But you have
along
not
the
put it in the slides
yes,
regarding the consistency and all. Okay.
Do you know about the 579 rule, palpation of liver? What else should be mentioned in liver palpation, apart from this palpable below the right costal margin? How do you look for the left lobe of the liver? That's why the extent is important, the site is important. So one thing is below the right mid-clavicular line. Another, you should also examine the epigastrium,
yes.
not to miss the left lobe of the liver. So both areas you must say. If it is not present, it's better you say it's not present. The there is no left lobe of liver is not palpable.
But you are sure that it is form inconsistency, no? You are sure.
So it's just palpable, sir. So
No, consistency.
Consistency.
Form. You committed.
Yes, sir. Form.
You cannot retract. Okay. Your palpation is over with this.
Yes, sir.
Sir, excuse me, sir. We welcome Dr. Srinivas, sir. Sir, good evening and welcome, Srinivas, sir. As a mentor of Dharan.
Thank you. Thank you.
Thank you. Thank you, sir. Sir, please proceed, sir. Thank you.
Good evening, sir.
Good evening, sir.
Prasanth, sir, Arvind, sir.
Good evening,
please proceed.
Srinivasi.
Good evening, Prashant. I'm enjoying your discussions.
Your palpation is not complete, Dharani.
Sir.
Since you have given more reasons for me to ask further. Anand, she should have mentioned something else also.
No,
What are the other organs that you should look into while palpating?
no palatable mass.
No palatable mass in the abdomen, sir.
More than that,
No free fluid in the abdomen informs there is no shifting dullness or
more than that. Did you examine for any renal mass?
No.
No palatable mass was found. No renal.
Okay.
Can you enumerate the differences between how to differentiate between spleen and kidney on palpation? What are the differentiating points?
Spleen will not be able to insinuate our fingers below the costal margin. The direction of the spleen will be towards the umbilicus from the left subcostal region, and that will move with the spleen will move with the respiration, and the splenic notch may be palpable, which will help us to identify spleen. While the kidney will be a palatable mass and which will not move with respiration. You will not have a splenic any notch in the surface of the kidney, and the axis of the kidney will be more perpendicular to the abdomen.
Another point will be the colonic band of resonance. There will be a colonic band of resonance over the kidney, whereas it will be absent in the spleen. So this 5 centimeter spleen, can you tell me whether it is mild, moderate, or severe?
It's moderates.
Moderate, sir.
Between what values is moderate?
4 to 7.
4 to 7. Is there any other method to grade splenomegaly?
Hackett's classifications.
Okay. So in Hackett's, this comes under?
This comes under up to the level of the umbilicus 3, sir. Hackett's 3, sir.
Okay. Can you tell me how did you look for this span, liver span? You said it is 6 centimeters. Can you tell me the method? How did you look for liver span?
Liver span, sir. Yes, sir.
Yes.
Upper border is by percussion from the 4th costal margin, sir. From upper border is by percussion and lower border is by palpation, sir. From 4th costal margin, we have to percuss down, and from where where dullness is noted, it is upper border is marked, and by palpation, lower border is marked, and it is measured, sir.
So what is the normal span at birth?
At birth, it's 5 centimeter.
5
Not
centimeters.
5.
Liver span.
Sorry, sir. 3 to 4. So
3 to
No,
5.
no. In
Is it age dependent or age independent?
at birth it will be high, sir, and after
No, for this child.
sir, this is age dependent only, sir, for this child.
so it is 5.6 to 5.9 at birth. It comes back to 5.5 at 6 months, and 1 year it is 6 actually. So 2 years I think it is 6.5. As given in our clinical book, it is 6.5. Okay.
Okay, please continue. Please continue, Dharani.
Percussion, there is no shifting dullness, and an auscultation, vowel sounds are here, there is no buoy, and other system examination were normal, sir.
Other system examination, if you are asked to examine one more system, which is the system that you should look into?
Cardiac, sir.
Cardiac, why?
Sir, secondary to cardiac causes, and secondary to cardiac cause, there may be congestion and this, and I have to examine RS also, sir, to rule out hepatopulmonary syndrome.
Okay. Arvind sir?
Okay, nothing, sir.
So what is your, so you are concluding the clinical examination?
Yes, sir.
So will you be presenting another summary?
Yes, sir.
At the end of the entire presentation, will
Yes,
you have
sir.
yes, okay.
2-year-old male child, born out of third-degree consanguineous marriage, previously well and developmentally normal child, now presented with upper gastrointestinal tract bleeding, variceal bleed due to a pre-sinusoidal cause, probably extrahepatic portal venous obstruction with anemia, and no congestive cardiac failure features, and no growth faltering with bleeding, now controlled with medicine and endoscopy procedures.
Why do you say extrahepatic venous obstruction, and how can you say there is no growth faltering?
Sir, height is in normal range, sir. There is no chronic growth faltering is there, sir. There is acute.
So you mean to say that it is acute?
Weight loss, acute. Height was in the normal sentence.
Was it normal or little suboptimal?
Height is near 15 centimeters, sir. The ideal height for this age is 92 centimeters, sir, and the child is 90, sir.
Okay. Why do you say it is extrahepatic portal venous obstruction? Will you get a firm liver and all there?
No, sir.
You committed that it's a firm liver. You are contradicting your own statements.
It was just palpable only, sir. That may be
just
dependent.
in the examination part, did you look for JVP, hepatojugular reflex, and all those things? Why do you say it is pre-sinusoidal?
History and examination wise, we did not have any sinusoidal cause. There was no evidence of liver failure in this child, sir.
So will that rule out post-sinusoidal causes?
No ascites and no veins over the back, sir.
No.
All cases need not have. So now that you have committed that it is EHPVO, so you'll have to evaluate in that direction. Suppose you would like to modify, how will you re-modify the statement? Anand.
Then, this is an probably a child with upper GI bleed. Probably it is most likely a variceal bleed. The cause could be pre-sinusoidal or post-sinusoidal, but with no evidence of with anemia, but no other evidence of congestive cardiac failure, growth faltering, and the upper GI bleeding is now under control with the therapies.
Arvind sir, are you happy with the summary?
No, sir, I'm not happy actually. I think you need not have mentioned it as pre-sinusoidal specifically. The pre-sinusoidal means it is intrahepatic.
Sir, both, sir, and that pre-sinusoidal intrahepatic congenital hepatic fibrosis may also present in the similar way, sir.
Okay. Oh. So you want to club extrahepatic and the pre-sinusoidal, both.
Yes, sir. Yes, sir.
Oh.
Sir, can I ask one question, sir?
Yes.
Sir, puddle sign, did you look for puddle sign in examination as a test?
Puddle sign.
You told only about no shifting dullness, yeah.
They mentioned no.
Puddle
I
sign,
think so, no shifting dullness.
puddle sign is negative. No, there is no.
They mentioned only about no shifting dullness. Regarding ruling out ascites clinically, we told only about shifting dullness, right? And also JVP was not mentioned. SAT told that.
Suppose you get shifting dullness after bleed, will you be surprised? Tarini.
Sir, shifting dullness
Okay, we'll just move ahead at 9 o'clock. Just the other date is the post bleed. You can get ascites, especially in EHPVN. Sorry.
Yes, sir.
Did you look for the direction of the blood flow, especially in that abdominal veins?
It was away from the umbilicus.
What does that mean?
It is the flow is due to portal hypertension. From portal to systemic direction, the flow is there. So
Okay.
there are only small veins, only two small veins were there in the epigastric region, and both of them, the flow was from below upwards.
Okay. So your examination, everything is now over. So how do you like to investigate this child?
From basic investigation.
Not in the customer.
Dharani,
Sorry.
sorry, I don't know. Let me just make few things clear. So I am here basically as a proxy mentor today. I think last class, I think she presented this to Dr. Malati, and after that discussion, I think you're presenting it here, right?
Yes, yes, sir.
Okay. So what messages I think Dr. Prashant has wanted to convey to you is, when you are presenting this summary, they are not happy with this summary because certain major things you have to get concepts very, very correct. One thing is fine. You are saying it's upper GI bleed. Say it's a major upper GI bleed, probably variceal, fine. You're fine. When you want to commit whether it is a pre-sinusoidal cause or an extrahepatic cause, two things you have to mention is that child doesn't have a firm epitomically because you expect a soft epitomically. So that's one concept he wants you to know.
Okay.
Second thing is that ascites is unlikely, jaundice is unlikely, signs of a chronic liver disease or any stigmata of chronic liver disease are not going to be there. So why you are going to say that this is more likely extrahepatic is because I don't find the reasons to say it is chronic liver disease. Sir, I can't find a firm liver. I'm not able to find any abdominal veins. I'm not able to find any ascites or jaundice. Therefore, I think EHPBO is more likely.
But she has mentioned firm liver in palpation.
That I'm not sure. So maybe I think she was a little bit unsure and she committed saying firm liver. So that's what
She did
happened.
not type it in the slides, but on asking, she committed it is firm.
So there you should not do that. That's what he was trying to tell you.
Okay, how do you evaluate this claim? How do you evaluate with the bare minimum investigations, not in that traditional way of mentioning each and everything? Just how will you hit the diagnosis?
Ultrasound abdomen with the Doppler, sir.
Why? What are you interested at?
Case, first thing to look at these organs, liver, spleen, and everything. And in case of extrahepatic portal venous obstruction, the portal vein will be replaced by cavernomas sometimes. And any thrombosis, we have to look at it. And we have to look at the both right and left portal vein and about the direction of the blood flows in portal vein.
Okay. Any additional information? Suppose I believe your statement of firm liver.
Yes, sir. Liver echo texture should be seen, sir.
Other than that, any other findings from ultrasound?
Free fluid in the abdomen.
No, not free fluid. Any other organ pathology? If we discuss during the discussion.
Renal cystic changes in the kidneys.
Okay. Then
blood investigations.
Okay.
Complete blood count. In case of as it is an upper GI bleed, that may be drop in hemoglobin, sir. That's the one reason. And there is a splenomegaly to rule out hypersplenism, to look for anemia and thrombocytopenia, any cell lineages.
Okay. What is the finding that what will be the finding in peripheral smear that will be suggestive of hypersplenism?
Sir, Howell Jolly Bob is maybe there, sir.
Okay. What will you do next?
Liver function test, sir.
What way it can help you? Clinically, there is no ictros.
Yes, sir.
What way the liver function test can help you?
To look for any hypoalbuminemia, sir.
Suppose hypoalbuminemia is there.
Hyperbuminemia is an indicator of malabsorption and also an indicator of bleed in EHPVOs, risk of bleed.
Hypoalbuminemia.
So all questions are again directed towards the same thing right from start. Are you dealing with liver disease or are you dealing with bad veins? Are you having extrahepatic portal hypertension or are you dealing with a silent liver disease that is not apparent to the clinical eye? That's why these questions are being asked by the examiners. Whenever you have low albumin, you will have to first think about, am I missing a liver disease? If you test for albumin soon after a massive upper GI bleed, maybe you can have transient hypoalbuminemia. But otherwise, in any child with portal hypertension, if you are finding low albumin, you have to look for a liver disease, or you have to look for some other gastrointestinal cause like celiac disease, which is more prevalent in the North India. So, or you have to also look at your urine to see whether there are any other issues that might cause hypoalbuminemia. But in this context, questions are asked to find out whether are you still dealing with a silent missed liver disease, or are you confident that this is only a portal hypertension due to extrahepatic portal vein obstruction? The reason why probably Dr. Prashant is asking this is because sometimes you can have a silent cirrhosis in Wilson's disease. That cirrhotic nodule will cause a little bit of pressure on one part of the IVC, and then it can also cause a little bit of secondary portal vein thrombosis in cirrhosis. So even children with cirrhosis can develop portal vein thrombosis. So you have to look, so you have to know those questions correctly. And I didn't point out earlier, Howell Jolly bodies are seen in splenectomy, hyposplenism. They are not seen in hypersplenism. In hypersplenism, what you are expected to see is a decrease in 2 cell lines. So there is rapid consumption. So any decrease in either your, if you have anemia, leukopenia, thrombocytopenia, 2 out of 3, then you start suspecting hypersplenism. Prashant, over to you.
Then how will you proceed further? Now that the child has presented to in the casualty, what will be your priorities? Leave alone the diagnosis part.
First thing, hemodynamical stability in how
Yes.
best is to look at that and start from emergency treatments.
So how will you act? How will you act? Your assessment part is now over.
Yes, sir.
It's whether it is hemodynamically stable or unstable. If suppose it is hemodynamically unstable,
Unstable as
Airway breathing circulation will need to stabilize.
no, what will
Probably
you do? What will you do in the casualty?
so
What will you do?
circulatory part will probably require crystalloids in the initial part, and
how many cannulas you will put?
2 large bore IV cannula will secure, sir, and start on now crystalloids. Initially 20 ml per kg bolus. If no response, we can give to a maximum of 60 ml per kg. Meantime, we'll arrange a PRBC if bleeding is uncontrolled means, and start PRBC transfusion.
What is your target hemoglobin in this situation?
8, sir. 8
8.
grams.
Why it is set like that?
More than 9 targeting more than 9 hemoglobin can again increase the bleed risk of increased portal hypertension and bleeds.
Okay. If you are pretty sure that you are dealing with a portal hypertension, what is the drug that you will start?
Octreotide, sir.
What dose?
1 to 2 mg per kg bolus, followed by 1 to 2 mg per kg as infusion, sir.
So how early you should take him up for next procedure?
Yes. Once we control bleeding, the bleeding is uncontrolled, we have to do, we have to control it with the, we have to take for procedures, sir.
Okay, you think that the child is now stable and you are taking for endoscopy. So what all precautions you will take before you ship the child?
Arrange blood and blood products, sir. And coagulation profile is C, sir.
Then?
Good beta blockers. We started him on beta blockers to decrease the.
No. We have not done. We have not done anything right now. We have just taken for scopy only. Do we have that evaluation finding? Or are we or do we have to wind up here, Kritika ma'am?
No, sir, we have 10 more minutes, sir. We have 10 more minutes.
Okay, do we have the actual this thing? Scopy findings,
Sir, sir will be
Yes, ma'am.
Dharani, sir is asking you about the scopy finding.
Scopy findings, sir. Whether there is a variceal bleed or not, we have to look at it, sir.
Okay.
Where is
Size
For
of the
this
varices.
child, for this child, do you have the scopy finding? Sir is asking.
Don't have the images.
sir? Don't have the images.
Okay, if it is not there, leave it, leave it, leave it.
So this
What
is the
should be
same,
the
which child is this? This is the same child who got that banding done a few days ago, Dharni?
Yes, sir.
Yes, sir. Yes.
Few
I'm
days
not sure
back.
which child you presented, so that's why I'm this child has got large varices, I think, which required banding. Large varices with red color signs and it required banding.
Yes, sir. Required banding, sir.
I'm not sure which child you presented, but two, one with fundal varices and the other one with varices which did not require banding. So the one with the fundal varix, we didn't do anything. We just went in and came. The other one had a large varices which had a banding.
So this is child with fundal varices.
Okay, okay.
Okay, I think regarding intervention part, we will stop here, I think. Is it okay, Dr. Srinivas?
Yeah, absolutely. I think it will go well above their head for their level.
I think. So what is the message, Tharani, that you have learned? And Anand also.
We should be very broad and while presenting a case, sir. We should not narrow down the diagnosis.
It is all the problems come because you have one diagnosis in your mind, then you try to arrange the history in such a way that it suits that particular thing. So it should not be that way. It should be very open and you should explore all the options. So you should follow a very structured approach. What is the clinical diagnosis, the site of pathology, the likely pathology, that way only you should proceed.
Okay,
I think Dr. Srinivas, I think they missed that foreign body and all. Is to a foreign body and all those things. They were, from the very beginning, they were skewed towards portal hypertension.
Oh, okay. Sorry, I joined late because I didn't think.
Initial part, I was basically discussing the likely site of pathology, why the likely site of pathology is upper GI tract and all those things.
So I think here most of the time in the case, the examiners are not very happy to find out whether you got the diagnosis correct or not. They want to know your concepts or the basis on which you arrive at the diagnosis. So if you said like this is a possible variceal bleed because this is a massive upper GI bleed, they'll be fine. And if they ask you whether you think it is extrahepatic or intrahepatic, if you said like this is more likely to be extrahepatic because I suspect this, you still have an option open to go back to intrahepatic at any point of time. So you can always say that no, I have not done examination, or after you've done examination, you can say like no, I would like to do imaging before I say that there is no liver disease.
Even before going to the examination part, she committed that it is HPV.
Grossly, Dharni, you have to say, I suspect it is more likely ESPVO because, and then put in whatever you want to say. Before examination, nobody can be dead sure that this is EHPVO. You can guess saying this is more likely, that is less likely.
Okay, sir.
Then after examination also, then you have to look for those things and say like, okay, now this is more likely this, that way. So that quite often, sometimes, no, in this age, we do find well compensated liver disease, also presenting without jaundice with upper GI bleed.
Okay, sir.
So sometimes you find that somebody with a Wilson's disease suddenly presents with an upper GI bleed. We will be under the impression it is only EHPVO because there is no jaundice, but then they turn out to be a compensated Wilson's disease, but with cirrhosis.
But here it is only 2-year-old child.
Here it is only 2-year-old, 3-year-old. Sometimes you'll have somebody with congenital hepatic fibrosis, and you might miss that left lobe of the liver. So it's useful to have a broader differential diagnosis.
Suppose the spleen was a little large. I mean, massive splenomegaly. Will your differentials change? Harini?
So last
Suppose if it was a massive splenomegaly.
Common
Anand?
causes, no?
Anand?
No, sir. Not sure.
not
Splenic vein thrombus.
thrombosis of splenic vein.
Common things.
Post viral and post viral infections, post viral infections.
The pathology remains the same, but you see, I mean, portal hypertension is there, but you are getting a large spleen.
What?
Drugs. You can get either storage disorder or non-cirrhotic portal fibrosis, even though the age is slightly odd. Srinivasji, shouldn't we consider
Yes.
storage disorder and NCPF also? Suppose it was splenomegaly, massive splenomegaly.
Yes, yes. Only thing is most of the time, I think, yes, you're absolutely right. Sometimes we have knee and peak disorder, and sometimes children with Gauchers who present with this kind of thing. But most of these children also have a lot of jaundice by the time they present with portal hypertension.
Okay. I think
Bhavani, overall, you've done well. Not to worry.
Okay.
There are 2 points to say that you didn't do well, or 2 points to keep in mind where you should improve. You shouldn't commit on firm liver. You shouldn't commit on veins if you are
Okay.
thinking it is extrahepatic.
Okay.
was I a bit harsh?
No, sir.
Eh?
So, Dr.
Was I a bit
Prashant
harsh?
gave a lot of useful tips. I don't think he was harsh, but Dr. Prashant is a pediatric gastroenterologist. He's a DM. So therefore, you have to live up to his standards and grow to become to have a higher standard of your presentation.
Okay.
So that is the only thing where I think there is a difference in the expectation level as well as where you're coming. But for your level, postgraduate, whatever you're presenting, I think you did a very good job. And if you want take-home points, you don't be dogmatic about saying that this is only this. Say like this is most likely this. And second point is firm liver and veins. They are not usually seen in extrahepatic portal hypertension. So that is the only take home you need to take.
Okay, sir.
I think Dr. Arvind is waiting with
Arvind sir, any
presentation.
more questions, sir?
That too, for a pediatrician's perspective, since it is left to the experts, gastroenterologist, for their technical expertise. For a pediatrician's perspective, I would like to know better about anthropometry. So I think it is a very inadequate, your anthropometric parameters. I think a growth chart could have been added, and more parameters like mid-upper circumference, head circumference, weight for height, the weight for height centile, everything should have been added for a normal pediatric case presentation, leaving out your proper technical details. So that should be the expectation from a pediatric examiner.
Okay, sir.
Okay, sir. I have to say that this is the most interactive chat box session. I should thank Dr. Gaurav, Dr. Pradeep Reddy for that. Dr. Gaurav has told that interpretation of anthropometry should have been done, whether it is, what do you think, it is a stunting or wasting or whatever it is. And he has also quoted that you have to tell about weight for height. And Dr. Chidambaranathan, thank you. Dr. Ramya, everybody has contributed. And Dr. Gaurav has asked why not it is Budd-Chiari syndrome.
No significant hepatomegaly in this child. Not so.
Ascites is not there, right? Ascites is not there.
No signs of
Experts, sir, please. Sir, Prashant sir, Srinivas sir, your comments?
No, usually, yes, butt Chiari is causing a portal hypertension. Sometimes it can present without ascites if it is a chronic butt Chiari. Acute butt Chiari presents with tense liver and some ascites. Chronic butt Chiari can sometimes present without ascites also, but usually you will have a bigger liver. You don't expect to see a just palpable liver. You expect to see a much bigger liver. And for some butt Chiari to cause a massive upper GI bleed, it is generally rare. Usually they present with hepatosplenomegaly, they can present with ascites, but for them to present with also an upper GI bleed to cause so much portal hypertension, generally much more rare. We don't usually see them present with that kind of bleed.
Janani ma'am, your feedback, ma'am. Ma'am's online, I think. Janani ma'am, are you there?
Yeah, I was actually
has
in the
commented-
flight and
Yes, ma'am.
yeah, I was in the flight and
Okay.
I just logged in when I landed at 8:30. I think the students could have done better. I think Dr. Arvind and Dr. Prashant asked very valid questions. I think probably they'll do better next time. Thank you.
Ma'am, they did well, ma'am. They were good. They were a bit
Yeah.
tensed, that's all. They were
Yeah,
good, ma'am. They answered almost all the questions.
Yeah.
So,
Thank you. Thank you,
Bharani
Dr.
and Anand,
Prashant
it was
and
very
Arvind.
good.
Your questions were very useful questions and very well discussed. Yeah.
Thank you, ma'am. Thank you.
To thank Dr. Prashant and Dr. Arvind for such a lively session.
Yeah, very nice.
Thank you. Thank you, sir. It was very nice hearing from you, sir, from such a legend. I also learned a lot of points regarding the technical details, sir. I also feel much better co-chairing with Dr. Prashant. Thank you, sir.
It was really like a university exam session, sir. Full of tense moments. Dharani and Anand handled it so well. Prashant sir, thank you so much for all the valid points and discussions. You were not at all ragging them. It was very useful. You were giving so much tips. And Arvind sir, thank you so much for the discussions. And Srinivas sir, thanks a lot for the inputs. All inputs were very valuable and semi-standard. They were all. And Thiru sir, are you there? Any closing remarks? Or shall we go to the short lecture by Dr. Arvind sir regarding how some important points on portal hypertension? Thiru sir, are you here? Thiru sir? Then Arvind sir, please share your screen.
Sure.
We will have a quick 5 to 10 minutes discussion on portal hypertension.
Is my screen visible, ma'am?
Yes, sir. Visible and you're audible, sir.
Okay. So this will be a very short presentation, though the slides are more. I think this is a pediatrician's perspective regarding portal hypertension. So objectives will be introduction, etiology, and manifestations, diagnosis, and management. So, as you all know, the portal hypertension is defined as elevation of portal pressure more than 10 to 12 millimeters mercury, or a hepatic venous pressure gradient of more than 4 millimeter mercury. And this is the pictorial representation of the portal vein and the splenic and inferior mesenteric vein. This is another pictorial presentation showing the short gastric veins and all the portosystemic anastomosis. So the portal hypertension can result from obstruction to portal blood flow anywhere along the course. It can be prehepatic, intrahepatic, or posthepatic. So this picture depicts the extrahepatic, pre-sinusoidal, sinusoidal, and post-sinusoidal. You can see the portal vein obstruction is almost 68 to 76%, whereas congenital hepatic fibrosis, non-cirrhotic portal fibrosis are 3 to 4%, and intrahepatic causes cirrhosis 24 to 28%. And this veno-occlusive disease is caused by pyroxylodone alkaloid, herbal tea. And the post-hepatic, you see Budd-Chiari syndrome, 30 to 13%. So the etiology, as already discussed, portal vein congenital abnormalities like agenesis, atresia, stenosis, portal vein thrombosis, portal vein cavernoma formation, splenic vein thrombosis, and we can add omphalitis, peritonitis, sepsis, everything in extrahepatic portal hypertension. Intrahepatic, all congenital hepatic fibrosis, Wilson's, alpha-1 antitrypsin, glycogen storage disorders, methotrexate toxicity, parenteral nutrition, extrahepatic biliary atresia, and choledochal cystic fibrosis. So, two main reasons, whether it is extrahepatic portal vein obstruction or cirrhosis. So, these are the sites of portosystemic anastomosis for all welfare of all PGs. You can see the left gastric and azygos veins, superior and middle and inferior rectal veins, paraumbilical and inferior epigastric veins in umbilicus, gastrorenal and splenorenal, and retroperitoneal and paravertebral anastomosis, the sites of portosystemic anastomosis. So all these are again represented here. So this is another picture showing the same. Clinical manifestation, I think bleeding is the most common presentation of portal hypertension in children. Splenomegaly is the second most common finding in children. Ascites is the presenting sign in only 7 to 21% of children. Children can also suffer from growth impairment, minimal hepatic encephalopathy, and impaired quality of life. Some develop portal hypertensive biliopathy. So these are the clinical features: UGI bleed, portal gastropathy with bleed, recurrent epistaxis, lower GI bleed. So these ascites and other signs of hepatic dysfunction will be present in intrahepatic causes. Extrahepatic is the consequence of portal vein thrombosis just outside the liver. It may have variable extension proximally into intrahepatic radicals, distally into its confluence, or entire splanchnic system. So this is the picture given in our OP guide, which shows the differences between cirrhotic and non-cirrhotic causes of portal hypertension. You can see there is history of jaundice, edema, and ascites in cirrhotic, whereas it is uncommon in non-cirrhotic. Hepatic encephalopathy is common in cirrhotic, is not seen. Signs of stigmata of liver disease may be seen in cirrhotic, not seen in non-cirrhotic. Splenomegaly, you see moderate to massive splenomegaly in extrahepatic, whereas it is only mild to moderate in cirrhotic. Synthetic function is deranged in cirrhotic, whereas it is well preserved in non-cirrhotic. Transaminases derangement is also present in intrahepatic cause, whereas it is usually normal in non-cirrhotic. So, probably this first point sums up Dharani's presentation. Almost 85% of children present with UGI bleed due to variceal hemorrhage. So, she may be right in considering EHPVO above all else, most commonly esophageal varices. Mean age of presentation is 6 to 9 years. Presence of GI bleed and absence of jaundice are 97.5% accurate in predicting extrahepatic portal vein obstruction. Splenic infarction is a complication of long-standing extrahepatic portal vein obstruction with massive splenomegaly. So Doppler ultrasound is the best non-invasive investigation for diagnosis. Portal cavernoma on ultrasound confirms extrahepatic portal vein obstruction. CT angio or MR portovenogram is indicated in cases where Doppler has been inconclusive. LFT is essentially normal, will be essentially normal in extrahepatic. Hypoalbuminemia, as already discussed by Prashant sir and Srinivas sir, may occur during bleeding episodes. Otherwise, it is a sign of intrahepatic cause. At initial evaluation, serological tests for hepatitis B and C infections should be done. All patients negative for hepatitis B infection should be immunized. So, signs of liver failure, as you all know, spider angiomas, palmar erythema, xanthoma, gynecomastia, amenorrhea. So, these are the clinical features of intrahepatic portal hypertension. You can see palmar erythema, clubbing, gynecomastia, spider angioma, and ascites. So, crevular Baumgarten murmur is a continuous murmur varying from low to high pitch, heard between umbilicus and lower sternum. This is pathognomonic of intrahepatic portal hypertension. Budd-Chiari syndrome, which Dr. Gaurav was very interested. You can see it can be either primary or secondary. Hepatic venous outflow tract obstruction, the absence of cardiac and pericardial diseases. The site of block is predominantly hepatic vein, combined hepatic vein and IVC, and isolated IVC. So, clinical presentation, I am skipping it for want of time. You can see this color Doppler imaging showing thrombosis and narrowing of lumen in the hepatic veins under IVC. So management of Bacchiari, I think liver transplantation is done only if all the measures for acute and chronic Bacchiari syndrome must fail. So cirrhosis, common causes already discussed, infants and younger children and older children. You can see all metabolic as well as congenital abnormalities also. So investigations, we have discussed about LFT, prothrombin time, ultrasound Doppler, transient elastography and liver biopsy. So management divided into emergency treatment of potentially life-threatening hemorrhage and prophylaxis directed at prevention of initial or subsequent bleeding. So variceal bleeding, ongoing bleed is assessed by tachy as well as postural drop in blood pressure. This grade of esophageal varices, all exam going PGs should be knowing. Backwards classification, grade 1, 2, 3 and 4. Small, moderate size, large, very large. Another location of gastric varices, Sarin's classification. Gastroesophageal varices 1, 2, isolated gastric varices 1 and 2. So 1 is GOV1 extending along lesser curvature and GOV2 extending along greater curvature. You can see this GOV1 and GOV2. IGV1 fundus, IGV2 other than fundus. Another classification will be Hashizume's classification, where F1 is tortuous, F2 is nodular, and F3 is tumorous. So, as already discussed, fluid resuscitation initially in the form of crystalloid infusion, hemodynamic resuscitation with packed cell transfusion. Reasonable goal should be between 7 and 9, which Dharani mentioned as 8. Correction of coagulopathy by administration of vitamin K and infusion of platelets or FFP may be required. NG tube should be placed to document the presence of blood within the stomach and to monitor the ongoing bleed. Endoscopic therapy, as our experts already mentioned, is done to locate the site of bleeding and control acute variceal bleed. Options for primary prophylaxis, beta blockers or variceal band ligation. Secondary prophylaxis, sclerotherapy alone or band ligation followed by sclerotherapy. So EVL almost controls variceal bleed in all cases, can only be performed in children more than 3 years of age. Pharmacological treatment, vasopressin as well as octreotide, she correctly mentioned it, bolus of 1 microgram per kg, followed by continuous IV infusion of 1 to 5 microgram per kg per hour. This is a Sengstaken Blakemore tube for emergency control of hemorrhage by mechanical compression. Sclerotherapy, this is ethoxysclerol injection into the engorged vessel above the G junction. EST is effective in more than 90% of cases. Major complications of sclerotherapy may be ulceration and perforation and later esophageal stricture. So the another method is glue injection followed by second line therapy. So two agents are mentioned, N-butyl cyanacrylate and isobutyl 2-cyanocrylate used for gastric varices. So indications for shunt surgery, emergency as well as elective. In shunt surgery, emergency only when all conservative measures are failed and still there is acute bleeding. Elective complications of portal hypertension like large varices, portal biliopathy, bleeding varices and splenic infarction, massive splenomegaly affecting quality of life, symptomatic hypersplenism. So child Fuchs score is done to assess the suitability of a patient for shunt surgery and prognosis. Surgical procedures are broadly divided into shunting and non-shunting procedures, and shunting again selective and non-selective. Non-shunting, we have splenectomy, Hazard's operation, terminal esophago, proximal gastrectomy, and the esophageal transection. So this is another method, TIPS, transjugular intrahepatic portosystemic shunting, emergency procedure to embolize and give balloon tamponade to bleeding gastric varices. So complications, HPS, HRS, hepatic encephalopathy, ascites, portal biliopathy, and hypersplenism. So management of ascites, all of us know, sodium restriction, spironolactone, furosemide, IV albumin, paracentesis, and again shunting as well as TIPS. Hepatic encephalopathy management, skipping for want of time. Hypersplenism, as she mentioned correctly, all cell lines reduced with splenomegaly. No intervention, partial splenic embolization and surgical shunting. Splenectomy may worsen variceal bleed in hypersplenism. So this is again the difference between extrahepatic, cirrhotic, BCS as well as congenital hepatic fibrosis. The prognosis, intrahepatic disease has a poor prognosis. Progressive liver disease and significant esophageal varices ultimately require liver transplantation. So these are the references, Nelson's, Piyush Gupta and Riaz. Thank you.
Thank you so much, Arvind sir, for that excellent sum up and adding many valuable points. Dharani, you should be grateful for having such a supportive internal. He's telling you, he has told us everybody that you are 97.5% correct in diagnosing EHPVO, and also he had always supported your management and appreciated throughout, and you should be really blessed to have such a university internal. Sir, Prashant sir, you told that one single finding you will do at the end of history to know whether it is, if you are allowed to, what is that one single finding, sir? You ask the students, sir. Prashant sir, you are muted, sir. You are muted. Sir, you are muted. Prashant sir, you are mute. Kindly unmute, sir.
Immediately after they concluded their history, no. Just to look at spleen and splenomegaly. That's what I was hinting at that point of time. But then I was not happy with that, especially with that head to foot examination. You know, they started directly from they directly went to abdomen palpation and all. Sometimes you can miss some subtle findings like telangiectasia and all. So I think when you are presenting in a real case presentation, no, you should be you should be very much more, what you call, a little more bit focused rather than concentrating on one specific diagnosis.
Yes, sir.
Okay, sir. Thank you so much, sir, for sharing with us your valuable time and making us more informative about the infant with jaundice or EHPVO. Sir Srinivas, sir, your closing remarks, please.
No, I think it's a very good session. I should thank both Dr. Prashant as well as Dr. Arvind for their contribution. And I should thank the presenters and the discussants for actively participating and making this a very, very lively session. And I should also thank the audience for asking so many questions.
They were bombarding questions.
Correct.
They were very active today. They are very active today.
And hats off to Kritika for making this very lively and engaging everybody and involving everybody.
Awesome. Thank you, sir. Thank you so much. Thiru sir, are you there, Thiru sir? Dharani, any remarks from you? How do you feel the program?
Very good session, ma'am.
I'm very happy with your presentation. You did so well. Good. This is how you will be like in exams. Thank you, Dharani and Anand. Thank you, Srinivas sir. Thank you, Arvind sir. Thank you so much, Prashant sir. It was so good discussion. Yeah, I really enjoyed very much. I learned a lot, sir. If there are no further remarks, shall we close the session, sir?
Sometimes we also become students when other people are asking
we're always students, sir. Always students. Thanks a lot, sir. Thanks a lot. Good night, sir. Good night, sir. Thank you, Prashant sir. Good night, sir. Thank you, Arvind sir. Good night, sir.
Thank you,
Thank you, Dharani. Thank you, Arvind. Good night.